Good morning, everyone from Boston. Good afternoon, good evening, wherever you might be. Welcome to this webinar of the Lancet Citizens Commission. My name is Vikram Patel. I am a professor of global health at Harvard Medical School, and I'm delighted to welcome all of you, our moderator, and our panelists to this webinar. A few words of introduction about the Lancet Citizens Commission, of which I co-chair along with Tarun Khanna and Kiran Mazumdar-Shaw. The Lancet Citizens Commission on Reimagining India's Health System is an ambitious cross-sectoral endeavor that aims to lay out a citizens' roadmap for achieving universal health coverage for all the people of India. And one of the very important guiding principles of the Commission is that health is a concern of very many different stakeholders and perspectives. And we have explicitly, over the last 4 years, conducted a series of different studies as well as consultations to ensure that we hear the voices of these diverse stakeholders across the spectrum. One of the important mechanisms through which we conduct these consultations is to have public webinars. And this webinar is one of a series of such webinars that we have hosted over the last 4 years. I'd encourage those of you who are interested to listen into the previous webinars. You can find the recordings of these webinars on the website of the Commission, which is www.citizenshealth.in. We will insert the URL again in the chat of the Zoom so that you can actually browse the website after the webinar. This webinar, like all our other webinars, is recorded. It is intended ultimately to really provide a record of the conversations we are going to have today for academics, for practitioners, for the public to engage on the issues regarding universal health coverage in India. If you'd like to stay engaged with us, please do sign up for the Commission newsletter, which again you can do on the website, where you will receive information about the progress of the Commission. The Commission draft is currently under review with the Lancet, but also for future webinars and our plans for a launch and the post-launch activities that we hope will happen in the course of 2025. So I want to now turn to this particular webinar and introduce our esteemed moderator, Dr. Indu Bhushan. Dr. Bhushan has had a long record of service in India and in the development sector. He was an officer of the Indian Administrative Service and was the founding chief executive officer of Ayushman Bharat, which is India's flagship health assurance scheme, which currently covers more than 500 million people. Dr. Bhushan helmed the Ayushman Bharat initiative from its inception in 2018 to 2021. He also led the implementation of the National Digital Health Mission, which is now called the Ayushman Bharat Digital Mission, which is an initiative to develop the backbone and ecosystem for digital health in India and is an integral part of the plans for universal health coverage. He's also served as the Director General of the East Asia Department of the Asian Development Bank and held multiple positions within the ADB, including as Director General of Strategy and Policy. He was also chair of ADB's Health Sector Community of Practice for a decade. He's currently chairperson of the NGO Partnership for Impact and serves on the board of several corporate and not-for-profit organizations. And of course, most importantly, Indu is a colleague as a commissioner on the Lancet Commission for Reimagining India's healthcare system. We're very grateful to you, Indu, for having to have moderated this panel, for having helped assemble the team that we have of incredible panelists. And I'm going to hand over to you now to take us through the next 90 minutes.
Thank you very much, Vikram, and thank you very much for very generous introduction. And I also want to thank our three panelists who have come from three different time zones. For one, it's well past midnight, and for one, it's early morning. So thank you very much for sharing your time with us. Just to give the background, the topic for today's discussion is private sector in primary health, PHC. Is it a catalyst for progress or cause for concern? Now, of course, all of us know that private sector plays a huge role in health sector in India, and the role of private sector in tertiary care and curative care is well acknowledged. Ayushman Bharat that I started, of course, finances curative services, and the services are provided by public sector and private sector both. And people have a choice. They vote with their feet. They can go to public sector or private sector. But when it comes to primary healthcare, things are not as clear. Just to provide the context, of course, private sector does provide PHC in our country. Pharmacies and small clinics are actually the first point of contact for any health-related consultations. But the question is whether we should be proactively promoting private sector for providing PHC. Should government be promoting private sector for providing PHC? We have an eminent panel coming from three different countries and very different background. And there's some questions that we would like to pose to them. And one, of course, is that given the vast experience you have, we want to understand that are there some countries or some models that have shown that private sector can actually effectively deliver PHC, which is aligned to universal health coverage. What is the evidence around the world on this? Does the evidence show that provision by private sector is cost effective? Is it successful? What are the guardrails that one need to put in for involving private sector? But more important or pertinent question is that the PHC is very different from curative health, right? It has large externalities and some elements of PHC are public good. The question arises that why would private sector be interested in providing primary health care? There's a concern that probably they'll be just cream skimming. They'll be doing some parts of PHC which are profitable. So how do we encourage private sector to provide holistic PHC, and how do we encourage them to provide services to marginalized communities and remote areas where provision of services may not be that profitable? A related question is that how do you ensure that private sector is providing good quality primary PHC? Because there is a typical principal agent problem that once you have engaged private sector to provide certain kind of services, how do you ensure that they are indeed providing those services that you intend them to provide? And what kind of regulatory practices we should put in place to ensure patient safety and ensure that we can deter them from unethical practices? And like I mentioned earlier, that a large number of people already consult prime pharmacies and other clinics and informal sector for their PHC needs. So would it make sense to co-opt them and integrate them with the system? And so how do we make them accountable? How do we make sure that they are providing, again, a safe and quality services? Another question which comes up is that when we look at our insurance products, most of them don't include several elements of PHCs. So how should government provide incentives or maybe regulations to ensure that insurance products include elements of PHCs? And finally, one question which has come up is about the corporatization of private PHCs. Concerns are that if we give it to corporate sector, there may be distortion of incentives because they're large. They might actually take over the current system, which will neither be very efficient nor very cost effective. And some of the provisions which are currently there may be co-opted by corporate sector, and that may lead to a system like a situation where we are not getting good quality services. So I'll also like to seek your views about involvement of corporate sector in provision of PHC would be in the interest of patients and in general population, and will that be advisable? So I'll start with the Christian Beza, and Christian is like a rock star of public health and health systems, and he is currently the executive director of the International Center for Health Systems Strengthening, and also of the Center for Healthy Development. He's based close to Washington, D.C. He lives in a farm and does farming, but also a lot of other work. He used to be a professor of global health in University of Washington in Seattle, and he has held multiple global health positions, including the position of global director for health, nutrition, and population at the World Bank. And he's been CEO of Chilean National Health Insurance Fund and co-editor of World Health Report of 2000. So we couldn't have had better person to kick off this seminar today than Christian. So Christian, I invite you to now provide your insights and views on some of the questions that I raised, but maybe you can go beyond it and tell us how India should proceed in terms of involving private sector in PHC.
Thank you so much for the invitation, and thank you, Indu, for your very generous introduction. You are a good friend. It is always wonderful to reconnect with India. I had the privilege of working in India for a few years. A really big chunk of my heart was left there when I couldn't continue working. So I miss the work there. You are leading really pioneering changes in the country that determines the health of the world, basically. So really delighted to be connected. Let me begin by agreeing and reaffirming the importance of primary healthcare and this conversation. Primary healthcare is not only the key pillar for having real, effective, universal healthcare, but also is the key pillar for facing the big tsunami of non-communicable diseases. There is no country in the world as rich as it can be that will be able to face the non-communicable diseases and the communicable diseases mix still existing by building hospitals. It is really, primary healthcare is central. So I really congratulate you for the discussion, and I'm delighted that you invited me. Thank you so much. I believe that the overarching question that is behind what Indu just introduced is whether we should engage with private primary healthcare actors and providers, which present a serious problem in quality and in focus, or if we engage, do we run the risk of empowering this troublesome sector of the health sector and giving them, the light when they are really not suited to perform the duties of primary health care and do it well? And I have to say that, I'm old, so I've been working in this space for 30 years. This is a very familiar question and debate in governments and parliaments and in academia and all over the world. And so India is not alone in that discussion. It's something that I am very familiar with in the last 30 years. Seldom has a year passed where I have not been involved in this debate in Chile, my country of origin, in the US where I live, or many countries around the world. Let me anticipate my conclusion, and then I will make my case. So my conclusion is that I believe that the answer to whether we need to engage and steer private primary health care is a resounding yes. I absolutely believe that we need to aggressively engage from a public policy and finance perspective. And I would pose the question of, can we afford not to do so? And can India afford not to do so? The question, however, is how. So let me just explain what I mean. Private healthcare will exist whether we engage with them or not. So historically, and increasingly less in many countries, but historically many countries have chosen to ignore the development of private sector in the health sector, and in particular of private primary health care. And I think we have paid the consequences of doing so, from Brazil to Turkey, from China to Chile, and everywhere in between. The non-engagement means, in practice, that we are letting the private sector grow inorganically in any direction that they might prefer to go, with very little consumer protection, with very little incentives, being them regulatorily or financially, to go in the direction of public policy priorities. And therefore, it is, I think, one of the biggest lessons in the world is that we need to engage and make sure that we steer it in the right direction. I am sure that you are all aware, and some of you might not agree with what I'm going to say, but that the most famous primary healthcare system in the world, the GPs, the general practitioners in the NHS, is a private contract. GPs are private entities. If you don't believe me, take a very good look at the contracting system between the NHS and the GPs, which I've been studying for many years, and I seldom seen a more entrepreneurial and more private framed contract between the GP practices and the NHS. But the difference is that it is fully publicly funded and contracted, and there is a full policy engagement and a full financial engagement with all the conditions and the mandates that are required to steer them in the right direction. The need to engage with private PHT, especially true in countries with a limited fiscal space and with large out-of-pocket. I believe India is one of them, is very large out-of-pocket. In that context, private PHT will grow, no doubt about it, because the out-of-pocket financing coming from households will drive demand for a very fragmented, small-scale, but really rigorous primary health care. We've seen it everywhere when that happens. And as countries grow and purchasing power of households grow, it will happen, particularly if there is no regulatory framework or engagement from the public sector to steer in the right direction. Now, I think one of the biggest lessons I learned, and I learned personally in my role in government in Chile, but then in many roles, as Indu mentioned, is that if you let the private sector, being any level of private sector, but primary healthcare in particular, to grow inorganically and let it grow with the pace of growth of the country, it will be all but impossible to bring them back into the direction you want to have once they have consolidated their footprint and their power. It will be too big to steer. And we have learned that lesson all over the world. So I think the question is not whether to engage and not to fear that, we might empower them, but how? And I think there are two issues here. One is a regulation, and particular regulation on quality and on consumer protection, and some fiduciary regulations. Very, very, very big challenge in countries where out-of-pocket dominates and the system is very fragmented, and we are not very strong on the regulatory side, but that needs to be done. So it's regulation, licensing, registrations, consumer protection, including education and complaint systems, and on. I do believe that this is necessary also to engage financially. Indeed, as Indu mentioned, primary healthcare can have large positive externalities and benefits from public good interventions only if somebody pays for them. not only in the private sector, unfunded mandates do not get done, but also in the public sector. We might pretend we do, but if we don't finance them, they don't happen. And by their intrinsic nature, public goods and goods with large externalities will not be captured fully if they are not publicly financed. So if we want that to happen, we need to engage, and we need to engage in a way that will set the incentives and the necessary requirements and directions. Again, if you look at the NHS GP contracting, it is a very prominent feature of it. Now, the problem is whether, okay, we decide we engage, are they going to answer the phone? Do we have enough leverage for that? And, if you have an 85% out of pocket, it's probably, very, very challenging to do so. And this is where I think, and I have 30 seconds to finish I think this is where the conversation between whether we engage in primary healthcare, private sector, or not, is also linked to the urgent need to increase pooling and insurance penetration. As long as the households in a very fragmented way are there, the pooling and the purchaser of primary healthcare, it will be very difficult to have the leverage to be able to bring them into the right path and into the right incentives to provide quality services, including public goods and externalities. And in that sense, and this is the last question that Indu posed to us, in that sense that as insurance penetration or risk pooling and strategic purchasing begins to continue to grow, and Indu and what you have led, he's playing a big role in that. The corporate involvement is going to grow. There will be consolidation, and consolidation is probably needed. We always look at corporate as if they're big monsters, and they are. But corporate means consolidation. It will happen as the leverage of aggregated out of pocket through risk pooling will have more power. And this is where I repeat what I said. If you let the private primary healthcare evolve into consolidation in the absence of a strong, aggressive engagement, policy-wise, financially-wise, and regulatory, that at that time it will be impossible to turn them around. And I can testify that personally. I've been in that travel for many years in my own country. So I believe that the lesson worldwide is that leaving the private sector alone to grow inorganically has proven to be a recipe for problems. And I hope you decide to harness that power by engaging actively through regulation and public policy and financing. Thank you, Indo. I talked too long.
Thank you, Christian. And very clear message that without PHC, we can't think of UHC. And that's the fundamental thing that we need to do. Even for NCDs, we usually associate PHC with communicable diseases, but actually for non-communicable diseases, you even need even more. And you said we can't afford to ignore private sector. Whether we like it or not, they will be involved. And it is better to regulate them and work with them rather than ignore them. Otherwise, they'll become a monster that we'll not be able to control. And and here the issue of regulations, working with them, ensuring quality, ensuring consumer protection. But how to do that? Maybe we'll come back to that again in the second round. But let me invite my second panelist, Josefa, and I am really grateful that she joined us because it's 2 o'clock in the night for her, and she's a teacher and a researcher at the University of Newcastle in Australia, and she has held several research positions earlier in her own country, Chile, and also in Italy. And she has worked extensively on the issues that we're discussing, and we are just posting her CV on the chat box, so I'll not read out the whole thing. And I invite Josefa to respond to some of the questions that I posed earlier, and also what Christian mentioned just now. Yosefa?
Hi, Indu. Thank you. Can you hear me? Yeah.
Yes, yes.
Thank you for that introduction. I was a little scared if I was going to agree or not with Christian, but I'm very happy that I agree fully with everything that he said. So I'm going to try and maybe give some other examples, and also maybe touch upon some like specifics that he hasn't already, because I absolutely agree with the fact that we must engage the private sector in the provision of primary care, and that the government should definitely play a role as the regulator. So I think it is well established that, you know, health insurance markets, private insurance market or private provision markets without any sort of regulations lead to many issues, and issues particularly related to achieving objectives of efficiency and equity. That is well established, you know, kind of across the board of the political spectrum, and also across the board in terms of academics, you know, hopefully policymakers. And maybe a point that Christian was saying that I want to touch upon in this first point is why we should be looking at, you know, pooling arrangements, and should be looking at the financing aspect of this to fund or insure for primary healthcare. And I think it's known, you know, the issues that this poses to consumers, such as, you know, uncertainty and the high risk of losses that are now being fronted by out-of-pocket payments individually by consumers. By, you know, pooling these risks, we will be able to, you know, spread them and minimize losses. And also for consumers to be able to transfer some of this financial risk that they're currently assuming out of their pocket, you know, say to a third party, you know, the government and insurance, or so on. I wanted to give a particular case that wasn't mentioned by Christian, to just add upon the fact that primary care is provided privately in many sectors, and this is the case of where I live right now in Australia. Primary care providers, you know, are private individual entities that they can set either the individual practices or group practices, but importantly, they are funded by the government through a schedule fee. Here we call the Medicare Benefits Schedule. And doctors, well, this is a little bit, I'll draw into part of, you know, the good sides and the bad sides. Doctors are free to set their prices constitutionally here in Australia, but the government has regulations where bulk billing, where the doctors agree to accept the set fees and bill that full amount so that consumers don't face out of pockets and therefore access services for free. This has been declining over the past couple of years. So it's definitely an issue that here in Australia is part of the public discussion. An important aspect that I also wanted to cover related to my example, because I think it very well connects to the issue that India is discussing right now, is maybe the role of insurance or government in terms of covering for some of these costs. So currently, private insurance here in Australia cannot cover primary care. So this is an important deficiency that we have. And there would definitely be several benefits for private insurance to be participant in this arrangement. You know, the kind of the more funding and the more insurance that we have, that definitely will help. So some, just to name a few of, you know, this expanding also for insurers that I am sure are a very big part of the landscape also in India that will want to take part on maybe some of these arrangements. You know, instead of just footing some of the bills for some of the higher levels of care, you know, also playing a role in primary care allows them to coordinate care across the spectrum of provision, you know, lowering healthcare costs, and also being more prudent purchasers of care on behalf of the patients and consumers. this definitely will impact, for example, coordinating care for some of this, non-communicable diseases or chronic diseases that definitely need this as part of the strategy. Also, for the insurer side, and drawing on my previous comment on the necessity that also Christian mentioned of pooling risks, this also can help attract new consumers that might be interested in enrolling, that might be low risk and not really necessitating higher levels of care, but that rather currently consume and need primary care and that are paying out of pocket, and now potentially could have coverage through insurance, through some form of insurance arrangement. So that to just name a few things. Then I did want to touch upon quickly, I don't know how much time I have left, about quality, which is definitely an issue that is faced when we have, say, some sort of competitive element, or even if we don't have a competition element among provision, is the necessity, unfortunately, of regulating quality so that there is no quality skimping as part of the business model or the part of balancing a budget. All right, so even if we think about public providers, it might be that we're skimping on quality to make ends meet for a set budget that was set by the government. So accreditation standards, for example, that the government can set, publication of information on quality, so that patients and consumers can observe that are specific forms of regulation that could definitely be part of the toolkit. So maybe I don't know how much time I have left, if I need to leave it there, and then maybe for the questions I can elaborate some more. Yeah.
So thank you very much, Josefa, for sharing what's happening in Australia, and good to know that in Australia, and also as Christian was saying, in NHS, private sector actually is involved systematically in provision of PHC. But of course, insurance, getting the insurance involved, I think has been a problem all over the world. But also some of the regulations that are in place was also good to know. Now let me move to Dilip, Professor Mavlankar, and he, of course, is one of the best known public health persons in India, and he is currently distinguished professor, honorary professor for public health at IIPH Gandhinagar, and he was director of this institute for more than a decade earlier. He's worked with all major agencies, including WHO, World Bank, UNDP, UNICEF, and many others. And he's been on all various high-level committees that we've heard of, both at Government of India and Government of Gujarat. Again, we are putting his CV on the chat box. And Professor Mavlankar, you've been involved in many, of course, research projects, but also many initiatives which involve PPPs, including PHC. And so from your experience, what is the role that private sector can play in provision of PHC, and what kind of regulations are needed, what kind of incentives are needed to correct the course that they'll take, so that they don't go off in a direction which is not providing needed services to the population. So Dilip, you're on. You're on mute. You'll have to unmute yourself.
Thank you very much, Indu, and thank you very much, the Mittal Institute and Harvard, for inviting me. I will start with the title of the seminar, Private Sector in Primary Health Care, a Catalyst to Progress or Cause for Concern. I would add to this that it is not only a catalyst, it is an essential catalyst in India. Without private sector, we can't really manage or Because as Indu said, India, one must remember, is 1.4 billion, like I think 2 times the Americas, including United States and Southern America's population, maybe 5 times Africa's population, 3 times Europe's population. So if you really didn't involve private sector, it would be a massive engine or massive system you need to develop to provide a government related or government owned health system. So that is the first point I wanted to say. Second is this cause for concern? Yes, it is a cause for concern. And to give a very simple but physics simile, I would say private sector is like nuclear power. And the regulation is like the carbon rods which go into the nuclear fuel to control the reaction so that it produces very safe and continuous energy rather than an explosion. So if you don't manage it, it may explode or it may sort of overwhelm the whole system and have negative consequences. If you manage it well, I think it will definitely essential and lead to good results. Now with that, let me go back to India's history. Like before the British came, there were kings in India ruling, and they had some public, very little public health system or publicly provided health services. Largely people made their own arrangement. Ayurveda and other local healing traditions were there, where there were private contracts, meaning private payment or whatever systems. When the British came, they prepared or created some kind of a system for initially only the British soldiers and British officers, later on so-called civil hospitals for the public in the big cities. And that is where, when we became independent almost 75 years ago, we had this mixed system of traditional healing and modern medicine. And given the current numbers, almost 70% of outpatient care is in private sector, 50% or so of indoor care is in the private sector. The way the current government has programmed, or at least thinking, that we will have one medical college for each district, which is like more than 700 or 1,000 medical colleges and 200,000 medical graduates coming, no government will absorb all of them. So they will be in the private market going forward. So this is the current scenario. Now, other point I want to make is that when we talk of primary health care, many times we mix 2 different types of health. One is what I would call as primary medical care, where is the medical officer, doctor giving sickness care or some preventive advice, very little, but 80-90% of sickness care. And there is the other side, which is preventive or primary really health care or preventive promotive care, which has very large sort of canvas, unexplored even by the health department. I would ask you a question. Is a public garden a part of primary health care system? It is not a medical care system, but people can run, jog, talk, have good mental health. And now there are PhD students working on what is the positive externalities are coming out of a public park, a green area, a gym, a yoga center. Now, are these medical services? No, they are not medical, even though the government may want to classify as clinical services in India, but they are all part of healthcare. And you can't imagine that everything of this type, health promotion, would be publicly governed. Then we will be maybe worse than China in that sense of the before 1977 China, not now China. So my sense is, given the vast array of social determinants of health and their importance on chronic diseases and on health as a general, we have to have a multi-sectoral view, including large private sector and individual responsibility. See, no government is powerful enough to stop you for smoking. People keep on smoking. How many doctors will you have to keep advising people not to smoke? You have to have legislation, you have to have market interventions, and I don't know whether they are part of so-called primary. They are definitely not part of primary medical care, but they are part of public health and primary health care. So I think the Lancet Commission must think beyond the medical care model, because wherever we talk, British GP is it's a medical care. German private doctor who is publicly funded through the sickness funds is a medical care. But the large private and public jointly health promoting systems are equally and if not more important to think about. So that was another second point. Then if you see the history of India's public-private partnerships, very old partnerships exist in treatment and identification and treatment of leprosy, in tuberculosis, in family planning, in maternal and child health care, in urban health centers. Many urban primary health centers were run by medical, the NGOs, if not private players. Many medical colleges, why I'm bringing medical college, because the way Indian system is structured, medical college also provides primary care. A secondary hospital also provides primary care, because anybody can walk in any facility as of now. You don't need. There are other public programs, just to mention Gujarat, which is a state in Western India with about 70 million population, had an interesting program of providing delivery care free of cost for poor and tribal through a program called Chiranjeevi program, and where in sub-district level there were 8 or 10 obstetricians available in the whole state. Sub-district level, this program enrolled 800 private obstetricians to provide free care. Now, such examples are there. Eye diseases, cataract surgery program. Of course, it is not, one could say it is not primary, but eye disease care is primary. Lots of NGOs are there which provide for eye care. And with now telemedicine and other kinds of things coming up, there are vast opportunities for providing care in the remote and distant areas. So basically, what I would say is that private sector, given its depth, size, capacity, we can't think of a UHC in India without private sector involvement. Now, given India diversity, will one model fit whole of India? No. We may have to have 30 models, maybe 50 models. Because sometimes I think United States with 300 million people have 50 states. India with 1.4 billion people have only 30 states. So our states are also very diverse. So we need a whole repertoire of different models of primary care, involvement of the private sector. And that is where how to assemble it. We can learn from past experiences. I mentioned about Chiranjeevi scheme. I didn't mention, but there is also similar scheme of involving pediatricians to give primary care to children in rural areas. There have been schemes to provide additional nutrition to TB patients, and now medicines to TB patients through private sector. So there are almost a collage of maybe 100 or more schemes currently going on where private sector has been involved in one way or the another. And there is a lot of learning which can be brought together to see where it has worked, where it has not worked, what are the kind of challenges. There are examples where good NGOs, well-meaning NGOs took up the primary healthcare responsibility, and finally were fed up with the government management and they gave it up, that we don't want to do it, we'll run our own. So there are lots of lessons to be learned. Now, the question you also raised is, how do we manage this kind of a public-private partnership? And will it lead to increased cost, increased fraud, increased corruption? I say yes. If as a government, if you can't manage the contracts properly or can't structure the contracts properly, private sector also has maybe black sheep. Not only black sheep, they are also in the market. So if there is an opportunity to be exploited, they will exploit it. So you have to regulate. And India has very strong regulatory mechanisms. If you see our stock markets, our banks, our insurance companies, our electricity utilities, everybody has a fairly good, if not ideal, regulatory mechanism. So I can't imagine that we can't set up or we don't have a capacity to set up a good regulatory mechanism. So we have to have a good regulatory mechanism when we enter into anybody with a contract. About 50, 100 years ago, contracts I have seen were just one letter. Okay, Red Cross has given this primary health center to run. Finished. And we will pay the salary of the staff. That was the contract. Because it was a gentleman's time and gentleman's contract with a fairly reputed NGO who were headed by fairly reputed people. So the chance of frauding was very minimal. But now we are in a different environment. We are in a very different market environment. So it's also, when we choose the partners, we have to see what is the motivation of the partner and what is the risk of involving the partner and how do we monitor that. And there, some of our weaknesses may come. We have very poor data systems. We have very poor, of course, it is changing with Ayushman Bharat digital mission and all, it will change. So we are developing mechanisms where we may be able to monitor better. The other thing is some of the lessons, and I did talk to some people who run these partnerships in India still now. They said, yeah, I said, what is your challenge? They said, government money comes late. So what is promised doesn't happen, but we are used to it, so we manage. So my sense is, whereas on the other hand side in Chiranjeevi program, when initially the officer, Dr. Amarjit Singh, talked about this and talked to the private sector, the first concern was, we will not pay us. We will enter into contract. So what he did is that we pay you 50,000 rupees in advance on signing the contract so that you have much more. And that is what is done with private contractors all around. Building a road, building a bridge, building whatever, we give them advance. So it's not that unheard of, but somehow in the social sector, we are not understanding how to contract, how to manage. Of course, there are other more serious concerns which one has to guard against. I am not naming it, but under the table dealings and all kinds of things may come. But when we are afraid of this, have we measured the cost of inefficiencies in the government? There was only one study by the World Bank some years ago. I don't think that was repeated. That 30% of the health workers and 30% of primary teachers are not found on the place of work on any given day in India. So 30% of your investment without a due reason. So what is our ability to manage a large government system or even a moderately large government system? So we measure the risk on the private side, but we don't want to assess what is the wastage of money in the public side. What is the productivity of a public doctor or a public? And second side is that we don't have standards set up. I have been pushing and some people think I'm mad, that what is the time a government or private doctor should give a doctor for one consultation. The British GP gives 10 minutes, some places 15 minutes. Indian doctors may see or give 3 minutes to a patient. Is that a risk? It's a very great risk. And they were very happy to say, oh, we can't give 10 minutes to a patient because we have so many patients, we have so many less doctors. But we must have standards. My last point is that any market will work where you have standards and monitoring mechanism. And only then you could have a fair interaction between the market, private players, and the last point, the private player should also have fairly strong recourse. Even in Ayushman Bharat, we hear that thousands of, not thousands, hundreds of or crores are not being paid by government because of many reasons. Now, there's no recourse. The doctors and hospitals are stuck with unpaid bills. That also shouldn't happen. This partnership will not continue. So with that, let me stop. I think we have time for question and answer.
Thank you very much, Dr. Mavlankar. You gave a very different perspective in terms of what's happening in India, but also bringing the issue of social determinants and various aspects of PHC and what can be done by doctors, what has to be done multi-sectorally, and the kind of trust the two parties should have, and the kind of the preconditions which should be there for this partnership to work. And all three of you actually agreed with each other in most cases. But luckily, our audience doesn't agree with many of your issues, and we have large number of questions here, about 28 questions. But let me start with one question which has come up again and again in our deliberation in Lancet Commission. The concept of this managed care that has been used very effectively for regulating the services, keeping the cost low, and involving private sector. So let me start with Christian and others as well. What do you think of use of managed care for providing primary health care? What kind of problems you see with that model?
I mean, I'm very positive about the managed care approach. Basically, as I understand it, I think there are different understandings of it, that people get focused on a model. Let me just do it conceptually. I think managed care is basically the management of the health risk across the life cycle of your consumers, and in managing it in a network. And that hopefully will include both an integration of the sort of purchaser, risk pooler, and the networks. Now, if you do that, it has many advantages. It has some disadvantages. It can hamper competition if you don't regulate very clearly. It can be like a cartel of providers, and there is no choice. I'm very positive. Now, I do believe that there is a progression between a super fragmented pool and a super fragmented provider network, and the capacity to actually put together a managed care system. I think we need to begin to walk before we run, and I think managed care, and then the next step of managed care, where you actually, as managed care organizations like the ACOs in the US, you take risk. So that is sort of the ultimate step. But so I'm favoring it. I think that's great. It will happen only, I believe, if 2 or 3 things happen. One, if you have the leverage to actually steer the consolidation of primary healthcare in India in the right direction. And I don't think that without increasing risk pooling, increasing somebody who has actually have the money to give the signals, you will be able to do a right consolidation. And without consolidation, you know, we can have fantastic ideas, but primary healthcare will not answer their phone. And if 90% of the revenue of a perhaps from the households, they will be focused on satisfying a household with all the short-term blindness of us as consumers. They will not be focused on externalities or public goods or you know, all we have discussed. So I think there is an urgent need to steer consolidation through improving the pooling of the out-of-pocket as a first step. And managed care, I think, is a good expression. There are multiple models, by the way. So that's that would be my. But I am in favor of it as long as it's well regulated, as long as consumers are very well protected. You know, the HMO experiment in the US is famous in the US. It's not a very, people are not voting in mass for it because of consumer protection issues. But I do believe consolidation and network working is crucial.
Before I go to others, you know, some of the questions which come here are that managed care is associated with the US model. And so the question is that why should we be learning from a failed model? And US is not a beacon of hope for healthcare, right? And so is there any other country which has done managed care, which has effectively reduced cost and provided better quality services and expanded access to services?
Well, I think the NHS has done it. I mean, with all the problems that the NHS has. So the other side of this equation, other side of this coin, is the UK, isn't it? So we all just say, oh, well, the Americans are a bunch of, you know, capitalist, disorganized, money-making people. Let's follow the Brits, who are really nice. They have a big issue on incentives too. So I think I do like the way the Brits have organized their managed care system from a mix of private and public. I think somebody missed the memo on incentives, and I would have loved to have it more clearly up front in the UK system. I think the Americans also missed the memo on incentives and let this monster evolve without regulation for a long time. But that is mostly, I think, is a social contract issue. And I think the third reason is, and I apologize what I'm going to say, but I believe it. I think India's path is very similar to the path to consolidation that we saw in the 80s in the US. Very fragmented, very fragmented provision, very fragmented insurance. And then as consolidation of insurance began to move, then consolidation of provision began to move. Now, did it go in the right direction? I don't think so, but that's what happened. So I think there are lessons, very big lessons in that. That would be my answer. I hope that you will give me a visa after this answer, but.
No, but no, let's go to Dilip, because, you know, it is indeed correct that our systems are highly fragmented. And if we consolidate them through, say, managed care, would they be a problem that right now many of our poor people are getting access actually through this fragmented system, because they can go to those small clinics and other providers. But once they are consolidated into a corporate body, would they lose that kind of access without improving the quality of the system? So, and also India is unique in the sense that we have a lot of experience of NGOs, like you mentioned, who refuse to work afterwards with the government. So can we leverage some unique Indian experiences in terms of expanding this to PHC through this PPP approach, which is different from what other countries have done? Because our problems may be same, like in 80s in US, but probably our approach may now be different, because we can learn from the failures of others.
Yeah. So first of all, I must confess, I don't understand much managed care, but my perspective is any care is better than no care. So even unmanaged care is the first step. Then I would say go to semi-managed or care, then go to the third level of managed care, and then fourth level. So my sense is it is a stepwise moving. We will not go into Kaiser Permanente type system or any other system overnight or over even 10 years of time. So at least first thing to provide is any care. And I would even say that first, I have been recommending to the state government that decide what budget you want to give for outdoor care and give a voucher. We have so many private sector providers. People have to pay at the time of illness. Why don't you give a voucher of $10 if you can afford? Give a voucher of $20 per year per family. India has 200,000 families. If you multiply by 10, it is $2 billion per year. If you give a $10 voucher. So at least do something saying, take this voucher, you may misuse it voucher. You can collect it and give it to your friend. You can use to buy a toothpaste, but the voucher you can't buy alcohol or tobacco. That much must be ensured. But at least start providing some care. You can say, okay, this voucher can be encashed for any medicine. Take vitamin, take whatever. So my sense is we have to really be bold and provide. Currently, what we are providing is if you are sick to become hospitalized, then there is a free care available, which is of a very low and uncertain quality. Nobody monitors anything. Nobody even counts how many are dead or how many are living at the end of it. I'm just exaggerating a little bit, but see if any hospital in India, public or private, publishes its mortality rate. They said, no, we don't know this, all kinds of answers. Just the basic gross mortality is not being monitored. Cities are not monitoring. So my sense is we are way away from a very regulated system. The second is, how will everybody feel that if I tell an Indian that, oh, you need a wheat flour, there will be 20 shops in your city which will provide you cheap, good quality wheat flour. Go and line up there. No private market. It is essential. We must take it. If you need oil, go to that different shop. If you need, Indians by nature are used to a bazaar. So if you say that, oh, go to this, and that's what happened. We never integrated the private sector in the outpatient care. We said we will set up our own clinics. In city of where I live, Ahmedabad, 7 million people, 8 million people. We have 30, 40 urban health centers, primary health care centers. So one for 2 million people. In the same ward, when we did a census type study of private providers, including medicine shops, there are 700 private providers in one ward. Just the one we sampled. So my sense is the reality. Now, of course, one can argue that that is not the case in a very tribal, there is nobody. But there is some semi-literate or semi-qualified doctor. But he is the best doctor in that area. Like what Dr. Abhay Bang has been saying in Gadchiroli, that his trained healthcare provider is the best neonatal care provider in that village, because there's nothing for neonatal care for next 50 kilometers or 100 kilometers. So we have to also see the reality of what is available. And once you start empowering, suppose the tribal people have a voucher of 1,000 rupees per year, GPs will go there because there is money to be made. Currently, they are not going because tribals have no money, no cash income. All GPs, my own city has 8,000 private doctors. Whereas if you go to a neighboring tribal area, they are maybe not having 20. Because the money is concentrated, and as a society, we have not created system to redistribute the money in a different way. What we did was, okay, what model was there, saying government will open its own clinics and run it. So I think the other, I just quickly want to answer, Veena, whom I know has put a question saying unbridled private market will lead to 60% cesarean section rate. I agree. It will go to 100%, not 60%. But we did in Chiranjeevi program paid per capita basis for delivery, cesarean or no cesarean, and we could cap for almost 1 million deliveries cesarean section rate at 6 to 8%. So it is a matter of incentive. What you incentivize will get done in the private market. Thank you.
Okay, so Yusuf, I think maybe you can come in here and explain to us what kind of accountability, how do you ensure accountability, and how do you ensure that regulations are in place in managed care in Australia or any other country that you've have experience with? And also just adding that, how do you ensure that people who are poor, living in remote areas, can also access services?
Hi, Indu. So just maybe to clarify, my expertise is not particularly managed care, but maybe managed competition, which is a little bit different, but kind of the same. I just wanted to quickly add upon what both my previous panelists were saying. I think an element that was maybe missed is that managed care also has to deal with a little bit of consumer backlash. And I think that is particularly relevant in a fragmented system where individuals are used to choosing where they want to go, say by necessity or by proximity or by whatever reasons. And I think when you start, consolidating and integrating and maybe creating mechanisms, say, of preferred provision, maybe these are the ones that are going to be subsidized, or the vouchers are going to work, and so on, there might be some backlash there. That is definitely what has happened overseas, right? Because you take away some of these kind of good elements, maybe that some of these fragmented system or just systems that are led by consumers and their decisions have. So just to add that point. So I think in terms of regulating models of, say, vertically integrated systems such as managed care systems on a financing provision and governance level, there is definitely a set of preconditions that are the ones that should be in place in the best case scenario to have this work. Some of them might be a little bit out of the scope of a first round of regulations. I believe so, but some essentials would, and I've seen them in the Q&A of someone asking about this, is, okay, what is it that is going to be offered? So what is the package of, say, this primary healthcare service is going to be, so that can be standardized across the level of provision? So that is definitely one element that needs to be decided by the regulator. And I think the baseline is quite clear. There's already certain services that are being offered. So, you can go from there. And then, of course, look at maybe some neighboring countries that have great systems of health technology assessment that might be a little bit more similar to India. Thailand, I think, is a great case of the evolution of a good HTA model that is looked by kind of in transition countries. I think that is definitely the first thing. And then definitely a second element is going to be the funding. And here I touch upon another question that I saw in the chat is, how are some of the poorest people going to be able to afford any sort of system? And that is definitely, subsidies, and something that another one of my panelists there was saying in terms of these vouchers. So canalizing these subsidies, which, not only in India, everywhere in the world, even in the developing world, this is needed. There is going to be a percentage of individuals that in any country is not going to be able to afford care. In India, this, of course, might be to a magnitude that is not seen anywhere else, just because India is the biggest country in the world. So, wow, that is definitely a big ticket item. But subsidies, the pooling arrangement has to deal with and distribute them. And here's my last maybe essential say, regulation or accountability/incentive mechanism is going to be payments. So what we pay for, how we pay for, is going to drive what providers are doing and what they're not doing. So C-sections was mentioned. You know, if we pay for, you know, hospital stays in days, then, well, we are going to see that length of stays are going to increase, right? So then we need to do something a little bit different. If we're paying more for surgical procedures, and that might be, you know, a C-section, then of course we're going to see providers offering that. And even in the primary care sector, right? So we definitely need to look at some maybe more innovative models, or starting with also maybe some simple capitation, and then try to expand it into something else. We can't get too ahead, you know, and to looking at the most modern at this time. I think we need to start somewhere. So that would be my three main, I think, regulatory items that I would try to work on. Yeah.
Okay. Thank you, Josefa. So my question, I think, to all of you is that, is India ready for a managed care for primary health care? And if yes or if no, then what kind of three prerequisites that we should have, the things that we should be doing before we go for managed care? Any of you?
Well, I think yes and no.
Okay.
So I'm sorry that I'm now a professor at the School of Economics, so I got used to that. It depends or whatever. But I think India is not one India. I think Professor Mavala really put it very, very clearly. India is 3 times America. And so I think India is ready in certain segments of the market, more than ready to go for managed care, and probably is really the next evolution for better care. And you know, there are regulatory issues. I think the regulation is still fragile, but I think if the objective of public policy is to reach out to more rural areas, I would not put managed care as the number one. I think there are very basic issues that need to be dealt with. So sort of consolidation, both of the out-of-pocket and the provision. I think one will follow the other. I think making sure that the regulations that tend to be pretty good in paper can actually be enforced. And for that, you need to have leverage, and they need to answer the phone. And actually, you know, and so today they have no reason in the rural areas to answer, because 90% comes from households. They guide the priorities. And I think that my last comment is that a lot of care needs to be taken to the consolidation. I saw a comment about, you know, I do really good primary health care, but still I'm struggling to sustain my practice. As you begin putting all these pressures, consolidating out of pocket and better purchasing, solo practices are going to struggle. They are going to struggle, and they will not be able to sustain the response, the regulatory response. So before you get into very sophisticated, at that level, very sophisticated managed care, there needs to be a well thought process of supporting that transition. Otherwise, you may lose a tremendous numbers of, which we've seen, by the way, even in the US in rural areas, of practitioners because of the pressure that solo practice cannot actually take. So that would be so it's yes and no, ready on one side, let's go for it, but there are other, you know, initial steps in the rest of it. And my final comment also, sorry to say, you cannot ask the private sector to do things that are not paid by anybody. Yeah. You cannot ask a bureaucrat to do things that are not paid by anybody. Why would you expect a private sector to do it? Private sector has a different objective. Now, if you want this to be done, we need to pay. So if you want the poor to be rich in the rural areas, You cannot expect the private sector to build a center for one person every week. Somebody needs to pay. I think we need to pay. There is a consumption externality of our public policy and taxpayers to do that, but then we need to pay. We call it market failures, which are there to be solved by the governments. Sorry.
Yeah. Okay, so you mentioned that India is not one country. It's and similarly, PHC is not one concept. Like Dilip said very clearly or very nicely that there is a very specific medical component and there's a specific non-medical component. And what I'm getting from discussion is that maybe provision of medical component through private sector is easier to enforce as compared to non-medical component. So maybe I go back to, there's some questions related to Chiranjeevi scheme, Dilip, and someone has asked that uptake of Chiranjeevi scheme was only 16%. Was it successful? And someone is asking whether there were some issues related to Chiranjeevi scheme and wasn't it discontinued? Can you respond to this? And also my other question about whether India is ready for managed care for.
Quickly about Chiranjeevi scheme, it was meant for tribal and poor. So if you add tribal and poor at that time in India, Gujarat, it would be about 30% of the population. So it was never intended to be 100% coverage. It reached maybe 60% of the intended coverage. And we also, when we did some research, found that some people who are eligible but did not go, they spent their own money and went to private sector because they were still not convinced that if I go to a private provider paid by the government versus I go to a same private provider, but I am paying, I will get the same care. So my sense is it's also managing perceptions besides managing quality. What people feel. In India, we feel that if I pay somebody, I will get my work done quicker. And even in the government, in many places. Whereas in many countries, they will say, oh, government has paid this government agent, he should do. Why should I pay? So it's also cultural. So it's why the scheme was closed is another dimensions. Because many times as politicians change, bureaucrats change, the public system or authorities' perceptions of the program change. And they think that the previous program was bad, so close it down or put it on the back burner, etc., etc. Plus, this national program of Ayushman Bharat came, which sort of overrode the whole program of this, even though they didn't pick up the lessons of capping delivery payment per capita. They do pay higher for cesarean and they are going into the same trap, which somebody had mentioned that you will get higher cesarean section rate if you pay higher. So that is Chiranjeevi program success, and now why it is stopped. Some of its residual and affiliated programs are continuing. But it is also sometimes what we think government is not a sort of continued bureaucracy, but that person in that point in time and what he or she wants gets done in a good way. And once that person and that point moves, the political scenario changes, the things may again come back. So we may have to think of how will this system sustain. If you look at the British GP system or British NHS, no political system has been able to change it because it's so solidly entrenched in people's minds. The other question about managed care, and I think I was going to say that some cities and some districts may be ready and others may not be. But recently I heard a lecture, very interesting. He used the word saying some zip codes may be ready and some zip codes may not be ready, because within my city also, there are very poor areas, labor-dominated areas as compared to very rich areas, very well-endowed areas. And the same thing even in a one district, there is so much of variation. I think you have seen more districts. Do you think there is an average or a district which is very uniform? I think no. So maybe some areas are ready and we have to pilot. I think India will never be ready, the whole of it, in next 200 years. So we have to pilot it in, say, 100 or 50 zip code areas and see how it works. And if it works, then we have to enlarge the zip code areas which we cover similar to that. And this kind of solution may, like Chiranjeevi, we had this experience and we wrote saying it will cover or be good enough for 2/3 of Gujarat. It is not good enough for 1/3 of Gujarat because there is no private provider. So we had alternate, the government made alternate arrangements saying if a private provider goes in that zip code and sets up his private practice, we will subsidize. As we subsidize, industry is going to backward area. So we have to have a series of solutions, not only one. Thank you.
Okay. Yusefa, anything from you?
Hi, yes. So, I mean, I think I just fully agree with most of the things that have been said today, and just wanted to touch upon the connection to your question and also another maybe comment that I saw in the Q&A about universal healthcare. So while I think managed care is a model of care that, has everything to work, we should maybe start from the beginning and think, okay, universal healthcare coverage is about that cube, breadth, depth, and so on, and start thinking, well, how do we take what is currently there? How do we take those services that are currently being offered and formalize that and start expanding that? So who doesn't have access to that, and try to give them access through, mostly in this case, it would be definitely the financing side. So, and I think in that case, we can definitely get creative as governments and as regulators by how to leverage those fundings to be able to provide that care, to obtain universal healthcare coverage, as we've been talking with primary healthcare coverage. Say, let's start from there, right? Let's make that universal across India. Despite the type of model or arrangement to deliver that at this stage, bringing in, it has been said several times in this webinar, bringing in that 80%, 85% of out-of-pocket spending into a more formalized pooling arrangement, leveraging subsidies from the government, and also being creative to where that funding is going to come from in terms of, say, the tax base. So, in many countries, funding for healthcare doesn't only come from taxes, it will come from individuals, and it can come from even more creative areas, such as when I went to IHEA last year, to the International Health Economics Association Congress, and was talking to some insurance managers in Africa for the public sector. They were saying, well, we collected small dollars, maybe cents, out of patents of small cards that were given by the government. And, that was, say, small entrepreneurs, very small, single business owners, basically. And we worked with them to make them understand that now they're paying out of pocket, but now we're adding maybe a cent, 50 cents to this patent that they already pay, to be able to fund the care that they need to receive. So I think in that sense, we need to look really about broadening our sources of financing so that we can actually achieve this this universal healthcare that is the goal, right? And I think primary care is definitely the first step and right way to go. And I would maybe leave for some other iteration if we're going to do it in a managed way, or if it's not going to be in a fully managed way. Maybe that's like step 3 or 4. Yeah.
We're coming to the end of the seminar. It's almost 8 o'clock here, but I just want to throw one question which actually has come up in many times. If you look at managed care in an integrated fashion, for the PHC, the incentive that we have to give to the private sector is that you keep people healthy. And on the other side, they have the incentive to provide curative care and ensure that people are not healthy, right? So private sector has not worked on this concept of keeping people healthy. So how do we make sure that that incentive works for private sector, in which they can keep people healthy in the true spirit of PHC? And any last comment that you have to you want to make after looking at the questions? Then we can just.
So my financing bias is going to show up here.
Okay.
We have a saying in Latin America, it's a bad translation. It says, the one that has the funding decides what is the music going to be played. So, I do believe private sector is actually doing this, but the private sector is doing it because purchasers, the ones who are paying the bill, are saying, we are sick and tired of you billing us for every single little thing you do. And if you do that, the sicker the people, the more you can bill. When you change the way you actually pay providers and force them into incentives that, you will make money by actually keeping people, not by doing knee replacement, but by preventing people to need a knee replacement, is a complete change. And this is where I get a bit concerned about separating the conversation so much between primary healthcare and inpatient. Because if you do not have continuity of care, if you cannot manage the risk in the continuums of care, what you're doing is what Australia is doing and other countries are doing. You are setting all the incentives for basic things to be done at hospital level, which is extremely expensive and inefficient and very bad for people. The hospitals are dangerous. You don't want to have people inside hospitals. But if you set that incentive, so I think my final comment would be, if we continue to make these distinctions and we don't see this as a continuum, as a network, and we don't set the incentives right, we will continue to have a big problem. And I think we can begin with small steps, and we can go all the way to very sophisticated networks and ACOs. But private actors are extremely rational. You set the right incentives, they will respond. Now, if they're not charity. You don't set the incentives, they will not.
Yeah. Okay.
Yeah. My
right.
quick by 1 minute is that keeping people healthy is not a doctor's job. Unfortunately, we have confused it. It is a public health job of non-doctors. And unfortunately, in the government system, we didn't employ non-doctors on a very large scale. And when we even called it health and wellness center, we don't have a wellness manager employed in a health and wellness. We still run it by a doctor. So my sense is I want to re-emphasize that primary medical care is completely separate than primary health care or promotive and preventive health care. We as a nation reduced the TFR, total fertility rate, from 6.7 to almost 2.1 or something over 40 years. Most of it is not done by doctor. The sterilization operations were done, but the motivation were done by psychology people, social work, other community sort of engagers who worked with the community, and it is such a private behavior. So we have to think much more widely. Finally, nobody mentioned, so I just want to mention, if people are interested, look up the German social health insurance model. We did talk about US and Britain, but Germany has a very interesting social health insurance model, which is more than 100 years old, and one could learn from that. And it came out of workers' movements. Thank you.
Thank you. Any last word from you, Yusufa, or we can?
No, I just want to second what everyone has said. And just thank you, Indu, for this great and a very enlightening conversation, and also for the wonderful comments that I had a lot of fun reading through.
Okay.
Thank you.
Thank you all. Thank you to three panelists for all your inputs and insights. And thank you for more than 100 people who joined and sent a lot of comments, which helped in terms of our discussion. And obviously, I would not like to summarize the whole thing, but it was clear that all of you of course, agreed that private sector involvement, proactive involvement of private sector in PHC is needed. They're already there. We don't have a choice not to involve them. But how to involve them? Of course, there are views, and there are things that need to be in place. Most of all, of course, someone has to pay for it. Of course, they'll not be involved unless there is this payment, and payment also, which is more predictable, more they have trust in the system so that they can come. But of course, there are other issues, including regulations and addressing the issues of disadvantaged and remote areas that need to be taken into account. But also, PHC is a much more complex issue as compared to curative health, and different elements of PHC, how we get private sector involved will also be a challenge. But again, I just want to leave it at there, and thank you all for your participation. Thank you, Mittal Institute, for putting this together, and thank you, Vikram, for organizing it. Any last word, Vikram?
No, I just wanted to say thank you all, particularly Indu and our three panelists, for having made the time to join us today. What's very clear, there are no easy and straightforward answers. And I think for the Commission, the most important thing is to be humble and honest with the fact that there is a huge diversity in India. There are multiple options. No one has ever been fully tested. And I think one of the panelists mentioned the question of pilots, and that's exactly, I think, where we should be acknowledging that we don't know the answers to these questions, but we do need to address the private sector. I think there is also one very big difference between India and some of the other country examples, and that is that we already have a very large publicly funded primary healthcare system. And so we have to also carefully examine how, a competitive marketplace, which puts private and public providers in competition with each other, would fare, as opposed to having these systems work separately. And I think that's, again, a very complex and question. And, there are very few countries in the world with which you can really compare India with, given that we have such a robust and extended primary healthcare system, and one that actually the government is actually committing even more funding for right now. So I think that's another important concern. But thank you, Indu. Thank you all. Lots of food for thought. And we thank you again on behalf of the entire Commission.